My slides are visible? Anyone?
Yes.
Yes.
Yes,
Okay, fine.
ma'am.
Okay, fine. We will be discussing 4 pathologies, and they are very, very important if you are really learning a basic, the pathologies of the shoulder joint. Fine. So we'll be first learning the anatomy. Then I'll be demonstrating the sonoanatomy on the healthy volunteer. Then we will be discussing about the pathology of that particular structure, how exactly will be the clinical presentation, and how to go about doing an intervention. So this is the manner which we will be following today. Fine. And if you really want to excel in MSK, right, the foremost important thing is to be very good in your anatomy. So whatever I am going to teach you, listen to that very carefully so that, it is just getting registered on your brain and you're able to see what exactly you are supposed to see when I'm scanning, right? So when we say shoulder joint, we are basically talking about this glenohumeral joint, okay? There is a difference between shoulder joint and shoulder girdle. Do not get confused with these two terms. When we use these terms, we are basically talking about these 3 joints together. And when we are saying shoulder joint, it is the glenohumeral joint. So what exactly is that? We will be learning in our subsequent slides now. So when you look at the proximal end of the humerus, okay? So what you are seeing here, there is something which is rounded, okay? So this is head of the humerus, right? Now, if you see, the head is covered by something here, right? So this is your hyaline cartilage. And this is your anatomical neck. Now, once I'm moving towards the proximal part of the shaft, this is your shaft. So from the head, it is the neck. And then when we are moving towards the proximal part of the shaft, we are able to see 2 bumpy things here. One on this side and the other one here. So the medial one is your lesser tuberosity and the lateral one is your greater tuberosity. Now you have a passage in between these 2 tuberosity, as you can see here. So this passage is your intertubercular sulcus, or we are going to call it as bicipitoradial groove. Anything, okay? Both are perfectly fine. So what exactly you should know from this head, from this, especially the proximal portion of the humerus, you should know the head, which is a rounded structure covered with the hyaline cartilage. Then is the junction between the head and the shaft, that is the anatomical neck. Then you have 2 tuberosities. The medial one is the lesser tuberosity. The lateral one is the greater tuberosity. You have a passage in between these 2 tuberosity, and that is your intertubercular sulcus. Fine. That is what you should know as a basic course participant from this structure, right? Now, when you move to the scapula, you're able to see something which is flat, right? So this flat is your glenoid cavity, right? And as you are seeing here, this is your coracoid process, and this is your subscapularis fossa. This usually we discuss in our advanced courses. For your basic course, just know the anatomy part, that is more than sufficient. Now, when you're going to the posterior, right, you are able to see a bone like this, and which is now becoming broader here, right? So this is the spine of the scapula, and this is the acromion. So if I'm seeing the acromion from the anterior aspect, how it is? Like this. And it is sitting on the top of our glenohumeral joint, as you can see in this picture. These bony landmarks are very important because when you are a beginner in your MSK, then you should just palpate the things, put your probe, you will 101% you will be exactly there. Fine. That is the reason of learning all these bony things. So now this is the spine. So this spine is dividing the posterior aspect of the scapula into a fossa, which is above it. So it becomes the supraspinatus fossa. And if this is the spine, this becomes the infraspinatus. Anatomy is very easy. Just remember the name. If this is spine, something which is superior to it, it becomes supraspinatus. Something which is inferior to it, it becomes infraspinatus. And this becomes the fossa, and this becomes the infraspinatus fossa. Okay. And this is your acromion. This is the spine, which if I'm going towards the lateral side, it broadens up to form the acromion. Now, coming back to our glenohumeral joint, we have seen that head is rounded and this glenoid cavity is flat. So if one is round, one is flat, this is going to make this joint unstable. So in order to increase the stability of this joint, we have a fibrocartilaginous rim around it. And I hope you remember from your basic class how exactly a fibrocartilaginous structure look under ultrasound. Anyone can tell me? Anyone who remembers? Because this cartilage basic sonoanatomy you should know. Can anyone tell me how hyaline cartilage look under ultrasound and how a fibrocartilaginous structure will look under ultrasound? Anyone? Dr. Rekha, Dr. Princey, Dr. Kalpesh, Dr. Saurav? No one? You have not revised your basic class? Okay. If you don't want to... Yes?
Starry look, madam.
Pardon?
Star type look whitish.
You don't have to remember things like that. Okay. See, hyaline cartilage, whenever you say hyaline cartilage, how are you supposed to describe this in ultrasound is, remember there is a mnemonic for it, okay? Hyaline cartilage will always be present where you will be having a synovial articulation, right? And this will look homogeneously hypoechoic under ultrasound. Structure will look hyperechoic, okay? Not whitish. We are supposed to it got disconnected in between. Till what point you have listened? Anyone, please tell me. Because we have another batch which is going on and Dr. Chinmoy and Dr. Devjyoti are taking class there. So I don't have my colleagues with me today.
Hyaline cartilage.
Okay, hyaline cartilage. Fine.
Something to remember, ma'am, like something like that.
Okay. Thank you. I don't know. Suddenly it got disconnected. Okay, we'll go back. I think we were here. So my slide is visible and I'm audible, right?
Yes.
Fine. So we were talking about the skin. So skin will always be hyperechoic because it has got lots of connective tissue. So any connective tissue or a fibrocartilaginous structure will be hyperechoic. Hyaline cartilage will always be homogeneously hypoechoic. So this fibrocartilaginous structure which you are seeing here, we call it as labrum. And where all you will get fibrocartilaginous structure, shoulder, you have this labrum. When you go to the knee, when I'll be teaching you, it is meniscus, right? And you have a triangular fibrocartilage in your wrist as well. So there are so many, triangular fibrocartilaginous structures which are present in our body, but they look hyperechoic under ultrasound. Fine. So we have seen the joint. Now this joint will be covered by a synovial membrane, right? So this synovial membrane will be having an extension down. So as you can see in this picture, it is covering this joint and then it is coming down. So when it is coming down, this is the one which will be forming the sheath for the long head of biceps. Fine. So synovial membrane in the shoulder joint, remember that it has got a distal extension, and this distal extension is the one which will be forming the sheath for the long head of biceps. I hope you remember we from the basic class, I think Dr. Chinmoy has taken it for you, that tendons, there are two types of tendon. Tendon with a membrane and tendon without a sheath or with a sheath. So if it is with a sheath, you are going to have this parietal layer and then visceral layer. And then this will be the cavity. When you see some tendons, they do not have the sheath. Okay, they have a loose areolar connective tissue around it. And that will be forming, that will be just giving the nourishment to the tendon. So this you see in Achilles tendon. So all these basics of ultrasound, right, is very, very important because that is what is the foundation for us, right? Okay. So this synovial membrane has got a distal, I should say, projection, and this will be forming the sheath. Now, on the top of this, you are going to have, just let me see whether the recording is on or not. Okay, it is on. Now, on the top of this, you are going to have your capsule, right? So you have synovial membrane, and this will be then covered by the capsule. Now, these are the structure of today's, class. So one is the long head of biceps. So the long head of biceps, it takes its origin from the supraglenoid tubercle, which is present on the top of your glenoid cavity. And this will be then going down. And where it will go? This will be going down, and then this will be getting attached on the I should say the radial tuberosity. Okay. So this we are not learning today. We will just learn the origin because insertion we usually see again in the advanced classes. So it takes its origin from this tubercle, and do remember this course. Okay. It has got an